Together we achieve victory over heart failure.
Hello everyone, I am Dr. Anoop K R, consultant cardiologist, Vikethas Institute of Medical Sciences, Palakkad. So the topic is heart failure. So heart failure is a major problem in today's population. So the approach to heart failure has changed a lot in the recent times. We have divided the heart failure into three categories according to the ejection fraction. One is heart failure with preserved ejection fraction, where the ejection fraction is more than 50%. Heart failure with mildly reduced ejection fraction, where the ejection fraction is 41 to 50%. And heart failure with reduced ejection fraction, with the ejection fraction less than 40%. So the classification aims to find out the need for drugs in these patients. That is, each classification is important because it decides the management of the patients. For example, in a patient with heart failure with reduced ejection fraction with ejection fraction of less than 40%, what we aim to do is we have to add extra drugs for the patient, such as aldactone, that is spironolactone. Also, drugs such as ARNI, that is sacubitril plus valsartan. Also, we have to add more doses of diuretics so that the patient is symptom-free. In heart failure with the preserved ejection fraction, which constitutes a major chunk of the population, patient usually doesn't need much of the heart failure medications. That is, its ejection fraction is above 50%. But what you can do is that you can add diuretics, that is furosemide, for symptom relief only. Suppose a patient is having ejection fraction of less than 40%, then you can start on ARNI, that is sacubitril valsartan, spironolactone, and also drugs such as dapagliflozin, that is SGLT2 inhibitors. And some of these patients, later on, their ejection fraction will improve to more than 40%. And these patients still need to continue the drugs, that is ARNI, that is sacubitril valsartan, dapagliflozin, and aldactone. It doesn't mean that once the ejection fraction goes above 40%, these drugs needs to be stopped. Another point is that the cause of heart failure. So the sizable chunk of the population is ischemic DCM. That is, you have to exclude the coronary artery disease in these patients. So echocardiography is a basic screening in these patients. Then another group of population can have a genetic cause or a structural cardiac problem such as HOCM, non-ischemic dilated cardiomyopathies, valvular heart diseases, infiltrative disorders such as sarcoidosis, arrhythmogenic right ventricular cardiomyopathies. So there are various causes of heart failure in our population. So the screening for heart failure in population is based on ECG, echocardiography, and also investigations such as BNP, that is brain natriuretic peptides. And these patients who are having a low ejection fraction of less than 40% should be advised fluid restriction, salt restriction, control of the comorbidities such as type 2 diabetes, mellitus, dyslipidemia, and hypertension. And all these patients should be advised, those who are bedridden can be advised physical rehabilitation and various methods, that is healthy diet, lifestyle modifications for symptom relief. If suppose the patient is having an ischemic cause of such as coronary artery disease, these patients should be subject to coronary revascularization procedures so that their ischemia is getting relieved. So the patients who present to us in the OPD needs to have a regular follow-up, which is very important. And antihypertensives should be regulated to the extent of high dose that the blood pressure is well controlled. So the follow-up part is very important. So that's all. Thank you.